Welcome to RWJBarnabas Health's Health Talk Show. I am Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group. If you've been admitted to the hospital in recent years, chances are you've had your care managed by a hospitalist. A hospitalist is a relatively new specialty in healthcare, a doctor or nurse who only takes care of patients in the hospital. On today's show, we will learn more about hospitalists and their role as part of the hospital care team. We are pleased to welcome Dr. Payal Parikh, an internal medicine and hospitalist medicine specialist with RWJBarnabas Health Medical Group, and Robert Wood Johnson University Hospital in New Brunswick. She serves as the Chief of Hospital Medicine Services for Rutgers Robert Wood Johnson Medical School and is also Associate Professor and Assistant Dean for Transformation and Integration at Rutgers Robert Wood Medical School. Welcome to the show. Nice to meet you, and can you tell us a little bit about your background?
Absolutely. So, as you mentioned, I'm an internal medicine physician and a hospitalist specifically. I've been in practice for the last 15 years, including training. I went to medical school right here in New Jersey, Rutgers Medical School in New Brunswick, many years ago, and then trained in internal medicine at Boston University. Subsequent to that, completed my chief medicine resident year, and really fell in love with general internal medicine, and that's where my career took off. I worked as a hospitalist for my first year at Massachusetts General Hospital, and then came here. I've been here for 10 years now, serve as a hospitalist on the inpatient wards, working with medical students, residents, NPs and PAs, taking care of our hospitalized patients. In addition, I engage in medical education, quality improvement and patient safety research. As Assistant Dean of Transformation and Integration, I use my background in Lean Six Sigma principles to really improve healthcare delivery and solve healthcare problems for our patients.
So for the audience, what exactly is a hospitalist?
So a hospitalist is what I would call a primary care physician on the inpatient side. So for our patients that see their primary care doctors on the outpatient side in their outpatient offices, what we do is take care of them when they're admitted to the hospital. And we are what we call a general internal medicine or family medicine trained physicians. So once a patient is admitted in the hospital, we not only diagnose but treat their acute medical condition, keep an eye on the chronic medical conditions, hypertension, diabetes, and really bring them from the acute medical condition all the way through their hospitalization to ultimately discharge them safely and timely.
And do hospitals have specialized training?
So a hospitalist can go straight into the field of hospital medicine after training. Generally, it's 3 years of internal medicine training or family medicine training. There are general internal medicine fellowships that exist if hospitalists want to engage in further inpatient acute care training. And then throughout the country, there are hospital medicine fellowships that pertain more to the quality and safety aspects, operational efficiency aspects of hospital medicine, should the hospitalist want to go into more administrative or medical education avenues in their care.
And why is having a hospitalist important?
So a hospitalist is really the quarterback of your care when you're hospitalized. So working very closely and collaboratively with your primary care physician who cares for you on the outside. When you're admitted to the hospitalist is the one that's really caring for you 24/7, 365. The hospitalists are stationed in the hospital, watching and monitoring the vitals, the labs, the testing, and really coordinating the care, should we need it, with specialists, with consultants, to help you get through that acute medical issue that you're admitted for, and then bring you back after discharge back to your primary care doctor to continue on caring for you for your chronic medical conditions.
As a primary care doctor, I consider you part of the team, an important part of the team, because Since I have admitting privileges at several hospitals, if I actually had to go to every hospital every day and see patients in the office, I wouldn't see my patients in the office and they'd miss out on medical care. Also, you know a lot more about hospital medicine than I do also. You know a lot about drips and things like that that I don't remember and I don't have a recollection of. You know the latest data. You also know the specialists who perform well, etc. So when my patient needs to see a cardiologist or a pulmonologist in the hospital, you have them at your fingertips and you're able to do that. Also, if I only see that person once in a day and something happens during that day, I couldn't take care of them in the office. Right. You can take care of the things immediately. So the patient gets much better medical care by having the hospitalist than if I was taking care of the patient.
Correct. And what you highlighted is exactly what the field of hospital medicine is actually bringing forward. So it's a relatively young field, 27 years old, but that's exactly why it was born, just to be able to provide that hands-on care, minute to minute, day, night, weekend, for our patients that are admitted in the hospital.
And how does your role differ from other doctors in the hospital?
So as a hospitalist, I am that general internal medicine physician on the team caring for the patients. We are seen as the quarterback, really coordinating the care, not only from diagnosis and management to coordinating the recommendations from our subspecialists. The other physicians that are in the hospital, medical physicians, including our consultants, they can focus or tend to focus on one organ system. A cardiologist says the heart, a nephrologist, the kidney. Whereas as the hospitalist, as a general medicine physician, we look at the entire picture from admission to discharge. How are the medications interacting with all the various organs? How are they interacting with the medications that the patient may have come in with? And do we need to make any changes and adjustments by the time of discharge?
I actually call you the captain of the ship rather than
the quarterback.
Rather than the quarterback, because you are the one who has the ultimate. You have to know ultimately everything that's going on.
Absolutely.
Put everything together and be able to go from start to finish.
Absolutely, yes. So those terms are absolutely used, and really the captain of the ship, it transcends even more than just the medical care. We work very closely with our nursing colleagues. If there's any change in vitals, they call us immediately. We take care of that immediately, whether it's testing or imaging or medications. Work very closely with our physical therapist colleagues to get our patients out of bed and moving, case management, social work colleagues, so that we can get the right discharge plan at time of discharge and get our patients home safely.
Again, very important is the whole discharge planning, making sure that there's home care if home care is needed.
Correct.
Making sure if they needed to be discharged to a rehab facility that everything goes correctly with the transfer to the rehab facility. And if they're going home, making sure that you've gone over what discharge medications are, because sometimes what they were taking is different when they came into the hospital will be different when they're
Correct.
discharged, and to make sure that we are checking that we're not giving the same medication twice to the patient.
Right.
So how do you ensure patients understand their diagnosis and treatment while they're in the hospital?
So we see them every day, starting with the morning, reviewing the electronic medical record, reviewing the labs, reviewing the imaging, and then going in to see our patient, doing the history, whether it's a new history, they first came to the hospital, or a follow-up, how is the pain, if it's pain related, and things like that. And then doing the exam. I personally and many of my colleagues like to bring in the computer to show the x-ray to our patient, to show the lab work, and really do a shared decision making with our patient so that the patient understands what it is that they're admitted for, what are we doing for it, medication changes, testing, consultants, and then really coming up with a plan together to get improvement every single day.
Again, because we all part of RWJBarnabas Health and we all use the Epic EMR, we're able to transcend paper charts, and thus, in fact, you can actually see my notes at the time of admission. You can see my x-rays at the time of admission, so
Absolutely.
you can compare what's going on there versus what's going on prior to it. And I can actually see what's going on in the hospital. So if the patient actually calls me, I can tell them, yes, this is exactly what the right thing to do is, and the hospital is doing everything that I would be doing if I was there.
Absolutely. And you're highlighting a very important point, which is the transitions of care. So really the transitions of care between at the time of admission, from when the patient comes from the outside in, and then again at the time of discharge, when the patient is discharged back to you, the primary care physician. And really that is the most important part of both flanks, or most important parts of the hospitalization, and really takes a lot of coordinated collaboration with our primary care colleagues on the outpatient side to know what was the patient dealing with, what medication changes had they had, so that we can give the right treatment on during the hospitalization, and then again on discharge.
Right, the coordination of care with the patient's primary care is essential to the best care that the patient can receive, because it's that handoff that can
Correct.
always be a problem. The handoff going into the hospital and then the handoff going home, making sure that there's reconciliation of medications, making sure that, again, if the person needs home care, that's been coordinated prior to the person being discharged. Whether the person goes to a rehab and then goes home, that everything's been coordinated with the primary care so they're not left in a lurch.
Yep. Absolutely. And so that is an area of my research. I focus on transitions of care and how we can improve that handoff process so that our patients can not only be advocates for themselves to continue the care that they received on the inpatient side, and really to avoid readmission or rehospitalization and be able to continue on with their lives on the outside. There are 4 major tenets that we focus on to equip our patients with good transitions of care. Do they know their diagnosis? Do they know what happened during the hospitalization? What medication changes were made? And that's incredibly important to continue on the outside. And then what follow-up appointments? When do they need to see their primary care doctor? When do they need to see their specialist? And so this is a large area of not only research, but improvement actively in the field of hospitalist medicine.
It's very important, because that coordination of care with the primary care, with the specialists, and especially because some of the time the patient, when they're discharged, may go to different specialists than the ones who are in the hospital. That handoff, that transition really can make the difference whether they continue to improve or whether we have to repeat what was just recently done again.
Right. Absolutely. And so in the literature itself,
what steps
these are
do
the
you take?
4. Upon discharge, really it's a concerted effort. It's written and verbal education provided to our patients, both from the physician side as well as the nursing side. Patients leave with a packet of information that is a packet, and in it is embedded all of this very vital information. So not only with the patient advocacy, but also using our EMR, leveraging our Epic, sending Epic messages to our primary care colleagues that are taking care of the patients, both subspecialists as well as primary care, to make sure that that handoff is done. Do they need that chest x-ray follow-up? Do they need this medication change? And so really 2-pronged, one, the physician-to-physician communication, as well as the information provided to our patients.
And it's actually also the personalized care that you can give, because unfortunately when they walk home with the packet that's 12 to 15 pages,
Correct.
a lot of it they don't even understand, and they bring to my office and they said, what does this all mean? I have to go through all of that. So
Absolutely.
if at the time of discharge, either you or the nurse or someone goes over that, makes it much better for that transition of care. Because if there's going to be a problem, that's where the problem can exist.
Absolutely. And medication errors are cited as the #1 cause of readmission. And so that is even more paramount for our patients to understand which medications were changed, were held, dosing changes. I recently published a paper in the Journal of GIM with regards to exactly this, where dual communication, both written and verbal, provided to our patients improved transitions of care.
Which is why it's so important you're doing this transformation stuff also, because hopefully with everything that you pick up and knowledge that you gain from it, that can help on that whole transition of care and make less drop-offs in that.
Absolutely.
What is your approach to managing patients with multiple chronic conditions?
So generally speaking, the first step is knowing what the chronic conditions are, and that's an ask of our patients. You know, what medications are you taking? How often are you taking them? Are you missing any? On the inpatient side, the chronic medical conditions, if they're not impacted by that acute medical issue, we continue the chronic medical care that the primary care physician has started on the outpatient side. If, however, the acute medical issue is impacting the chronic medical condition, then we may need to make adjustments in hypertensive medicine, for example, or provide insulin when they're not on insulin on the outpatient side. Because the inpatient side really is more about controlling what's going into the patient to make sure that the acute medical issue is taken care of. And then throughout the hospitalization, as the acute medical issue is improved and improving, we start adding back the blood pressure medicines, we start adding back the diabetes medicines and other chronic medical condition medications, so that we start to transition while in the hospital the patient to the outpatient setting and get them back on their feet as if they were going to be taking their home meds.
Again, so you take care of the acute incident.
Correct.
You make sure that the chronic medical conditions are as stable as possible. You may have to readjust things, especially diabetics. Since they may be NPO without food for a while, they may be on IVs instead of oral medications, but prior to discharge, hopefully you've transitioned them back to as close to the medications that they previously had been, or you may make several adjustments. If, for instance, the diabetic is still out of control, you may add something to it with the suggestion to the primary care to possibly continue this afterwards to get that chronic medical condition under better control.
Absolutely. Yes.
Can you walk us through a typical day in the hospital for a patient under your care?
So we can start with a newly admitted patient. So a patient will come to the emergency room for an acute medical issue that could not be controlled on the outpatient side, needs inpatient care. Once the ER physician does the initial evaluation, the testing, the imaging, and feels that the patient is better served being admitted, the ER physician will call us, the hospitalist. So we go in, we see the patient, do the history, the physical exam, evaluate all of the testing and lab work, and then come up with an idea, a treatment plan of what may be going on day one, and then what we can do to help mitigate the concerns. Often at this time, if we need a specialist, we are the ones calling our specialist colleagues to come in and also evaluate that organ system and provide recommendations. So that generally is day one. Throughout the course of day one, also connecting with our nursing colleagues, we start discharge planning on day of admission. All that means is we start thinking about what is the home situation for our patient, what medications may they need on discharge, do they need any specific coupons or anything like that to help them get those medications. Physical therapy is often called on day one. And then as we progress through the hospitalization, through this interdisciplinary rounds, through the interdisciplinary collaboration, as well as the medical management, speaking with our patient multiple times a day, and especially during any changes in vitals or any testing needs that need to be discussed, any results that need to be discussed, continuously speaking with our patients and the care team as we move throughout the hospitalization. The team, and I reference the team also can include medical students and residents, so they may be at the bedside, and we often do medical education with our learners there, have them listen to a murmur, have them do an exam, so that we're also growing our next generation of physicians.
So the good news is that, again, the person that is seen in the ER, I usually get a call from the ER about what's going on, and they say they think they need to be admitted, and then they call the hospice. The hospice does a reassessment, so we get 2 assessments right then and there to ensure that they're going to the right place and being treated appropriately. At that time, the hospice makes the decision with the ER and the primary care about admission and where they're going. That'll be determined by how acute the illness is and what needs to be done. The hospitalist can look through the records, see the past medical history, see who the consultants are that the physician has previously used to see if they can continue using the same consultants, which again, another good reason for having an Epic EMR throughout the whole system is that it's one chart, one goal for everyone. And so they then admit the patient, then they go through they see the specialist, they have nursing involvement, they've got physical therapy involvement, if necessary, occupational therapy involvement. By day 2, social services hopefully come into the picture. And then once the acute event has improved and the person's ready for discharge, we have a whole team that's been seeing the patient, following the patient, and so at the point of discharge, it should be very easy to know how to discharge, where to discharge, and why to discharge, and that the family understands what's going on also. Because a lot of it also is if the communication between the physicians, the team, and the family itself, so they know what's going on.
And generally speaking, to add to that, the afternoon rounds are exactly that, to involve our family members, really bring them into the conversation, because they will be the ones that will be helping our patients on the outside as well post-discharge. And so really helping them understand, we often call family meetings if there's difficult decisions that need to be made, but really just having robust communication gets us a long way.
And this way all questions are answered also.
Correct.
What do you see as the future with hospitalists?
So hospitalists are a rapidly growing field. We are 27 years young, and more what we're seeing is that the hospitalists themselves are specializing. So for example, in New Brunswick, with the Cancer Center, I actually have hospitalists that are onco-hospitalists. So we give them further training in the general oncologic acute medical issues, and they are my onco-hospitalists. Similarly, post-cardiothoracic surgery, they come onto the hospitalist medicine service, and we care for our patients post-cardiothoracic surgery. So I have CT surgery hospitalists, and now I'm looking to grow neurosurgery hospitalists. So all that being said, hospital medicine is a growing field, not only in clinical care, but also hospitalists really know the operations of a hospital. So often serve as the input for throughput endeavors and reducing readmissions and quality and safety improvements. And so more and more engaged in improving the way we deliver healthcare.
For a patient that you're meeting for the first time in a hospital, what is the most important information that they can provide to you to facilitate their care?
I would say first and foremost, who is their primary care physician and who do they see on the outside from subspecialty care? What are their chronic medical conditions and which medications have they taken and when? I think those 3 pieces of information gives us a lot of information on what their medical care has been, what changes have been made recently, and then we can pick up from there and keep it moving.
And again, what people need to understand is you are part of the team.
Correct.
Which is very important. You know, when I had started in practice, we went to the hospital all the time. We saw the people in the hospital, and then we came back to the office, saw the people in the office. Technology has gotten much improved since I had first started. Many more things we can do in the hospital that we couldn't do then. And things move very rapidly in the hospital from the time of admission to the time of discharge. And we need someone who is basically the primary care for that patient in the hospital, who has the patient's best interests to be taking care of them, and that's what your role is.
Absolutely. The captain of the ship, really guiding from admission to discharge.
And again, with your education, with your being the associate dean, et cetera, you're bringing in a lot of information which many of us don't have.
And that gets to the operational efficiency side of things. So, you know, many times there are testing delays. Do we really need that MRI? Do we really need that CAT scan? Really thinking critically and using our evidence to suggest and speak with our consultants and say, maybe we don't need that echocardiogram right now. Maybe it's better served 6 months from now. And that is that then collaboration and crosstalk with our colleagues, our primary care physician colleagues on the outside for that patient. During the hospitalization, if the acute medical issue does get worse, we are very quick to call our intensivist colleagues, and that would be a conversation then for the ICUs. And so really watching, very closely monitoring around the clock for inpatient care does serve the patient much better. It gets our patients improved, and really length of stay, generally speaking, for one medical issue is about 4 days in a hospital, 4 or 5 days, and that's our goal. Our target is to fix the issue and get our patients out safely.
Well,
as fast as we
what
can.
we really want to do is quickly, but also efficiently, safely,
Yeah.
and with the best possible care possible, which is
Absolutely.
what you can do much better in the hospital than I could do as an outpatient physician. And you also have the knowledge of when they need to go, if they need to go and if things get worse, to the ICU.
Right.
You've got the you can get to the intensivist much better than I can, so they can get transferred if necessary.
Absolutely.
And again, your knowledge base, being that you have primary care, you understand what I understand. You're able to take care of the chronic diseases as well as I can take care of the chronic diseases. I may have that 30-year relationship with the patient, but your relationship from start to finish becomes very, very important in that hospitalization.
100%. And taking it even a step further, that family meeting or that afternoon touch base that I mentioned earlier, we also sometimes loop in our primary care physician colleagues. So if there is a decision that needs to be made or a significant change in medications, the patient can request, and often we bring in the primary care physician via phone or Zoom or something, so that we can all have a shared decision making. So once a patient is discharged on the outside, the care can continue.
And what's very good about the hospital system that you're part of is that I usually will get a call from the hospitalist at the time of discharge stating what went on, what's been done, what should be done as an outpatient also, so that hopefully, again, the handoff is very successful.
Absolutely, and that is the standard of care. As hospital medicine is evolving as a field, the handoff process is paramount, and we recognize the benefits of improving transitions of care. And so one of the standardized practices is exactly that, to be able to hand off and provide that transition of care to our colleagues and our patients.
Before we conclude, what else would you like the public to know about hospitalists?
So hospitalists are the captain of the ship. We see ourselves as an extension on the inpatient side of your primary care doctor. And if at any point you feel uncomfortable or want your primary care physician looped in, please feel free to just raise that concern, and we would be more than happy to loop in your primary care doctor so that we are all on the same page to get you improved fast and safe.
Well, first, you do a very good job at the RWJBarnabas Health, and it really is very good to have a hospitalist group such as your own that does this. I am very proud of the work that they do with my patients when my patients are admitted to the hospital and taken care of very, very well. And I can tell you that the transition of care really is much better when they come out of RWJBH than when they come out of some other systems. Other systems, first of all, some of them don't even have Epic as part of it, so it makes it very difficult when they do transition what happened during the hospitalization and what they were discharged on. I get a much better picture when they're all done at the RWJBH facilities, whether it's Monmouth, whether it's New Brunswick, whether it's Cooperman, whether it's Somerset. I get terrific transition of care. So there is no dropping of care at that point. They usually almost always get a call from the hospitalist also to tell me, this is what happened, this is what you should be doing. And they give me reasons. I don't get that at a lot of other systems. So I am very proud of having someone like you working and running this organization and running the hospital system the way you do, because I do know my patients do get the best of care by having your group do what they're doing.
Well, thank you for that. And if there's anything that we can improve, for all ears, always. Just for the public to know, even within the hospital, the Barnabas Health Hospital system, we have a network of our own hospitalists. So whether it's Somerset or Monmouth we all know each other. And so if a patient is admitted in New Brunswick and then subsequently at Somerset, not only can we review each other's records, but we can also use Epic to converse with each other to ask what happened last time, what didn't go well, what went well, and how can we improve this time.
Thank you for everything that you do for RWJBarnabas Health. Thank you, Dr. Parikh, for joining us here today. That concludes today's episode of Health Talk. Please remember that the opinions expressed here today by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call 888-724-7123. For more information about RWJBarnabas Health, please visit rwjbh.org.